today. And as you know, Sisters Network is governed by an elected board of directors and assisted by our medical advisory board. And our purpose is to save lives. And one of our interests is to provide educational forums such as Webinar Wednesday. So without further ado, I will go ahead and introduce our presenter. And just a quick note before I introduce today's presenter, the question and answer session will take place at the end of the presentation. So please note your questions and hold until the end, and we'll make every effort to address your questions. And we will also have contact information. We'll provide you with contact information for the speaker for any additional follow-up questions that we may not get to. Okay, without further delay, I would like to introduce our speaker, Dr. at Cancer Treatment Centers of America. And she was nice enough to come on board today to represent Dr. Citrin, who's out sick this morning. So we've had a switch up this morning, but we want to thank you all for attending, and I hope you all received the email with the change. Dr. T is board certified in internal medicine, hematology, and medical oncology at Cancer Treatment Centers of America. Prior to her position at Cancer Treatment Centers of America, Dr. T served as an attending physician in hematology and oncology at a Pennsylvania hospital. She has been published in Chest, a well-known clinical journal, and is a member of the American Society of Clinical Oncology and the Society for Integrative Oncology. Breast cancer. So Dr. T, I will turn it over to you. Thank you.
Hello, I'm using Dr. Citrin's slides, so I will probably go over them briefly and tell you what I know about triple negative breast cancer, and I will attempt to leave plenty of time for question because that's what's most important. The triple negative breast cancer, I tend to start by explaining that what is it triple negative of? What's positive and what's negative? And there are three things that and the three things we look for are estrogen receptor, progesterone receptors, and HER2 receptors. So these are the three things that this type of cancer we're talking about today is negative for. So the term triple negative simply means ER, or estrogen receptor negative, progesterone receptor negative, and HER2 new negative. And the reason that's important is that those three markers are targets for therapy. So they are things that we have treatment available for. And when those markers are negative, the only option we have to fight this cancer is really chemotherapy. So that's why we use it as a separate entity. But over the years, we found that it's not just the markers that actually distinguish this cancer, but it's a lot of other features that make this subtype of cancer different from the typical hormonally driven, most common breast cancer. And not only we know it's different in different ways, but we know within the triple negative, there are different subtypes of triple negative. Not all triple negative are bad because it's associated with this negative connotation, but there are so many different subtypes, at least three we can distinguish today amongst the triple negative. And there are patients who have triple negative breast cancer that behaves just like the hormonally driven breast cancer. So it's a lot that has changed from the previous name, and there are some new things that might be changing in terms of how to call breast cancers. And you may see in the literature or on the internet, luminal A, luminal B, basal type, and triple negative can actually be any of those. So here, in addition to just being triple negative being different, it's different in different patients, different patient populations. And it is more and that's different than just the access to care. It's not just by the means of maybe they don't have enough access to care, maybe there isn't enough health insurance, or maybe they're not really well taken care of. It's something different, just inherent to the biology of the disease in African American women. The other thing that's associated with this cancer is that it tends to be fast growing cancer. That's what it means, aggressive. Don't like to use the word aggressive too much, but it's really a rapidly growing cancer. But again, there are subtypes. There are the triple negatives that are slow growing, and people can have long life expectancy despite having stage 4 disease. But that's the traditional thought of triple negative breast cancer. This is not moving. These are some pictures of some triple negative breast cancers. You know, the things that it does, it can be quickly sneaking up on the women, and they call it feels a tumor. She feels that the tumor is growing very rapidly over just a couple of weeks between the time it's felt and calling the physician's office and getting to get an appointment and getting to get a biopsy and seeing the surgeon. It can be many weeks, in which case the tumor can actually grow, visibly grow. So these are some examples of some locally advanced tumors where you can see the inflamed. This is an inflammatory breast cancer when the skin is thickened and red. This is another locally advanced when there is a nipple retraction. These are typical signs that women can actually come under the skin when you really can't see any skin changes. So here's Dr. Citron puts good news, bad news. What I believe he meant is, yes, it is this big word of triple negative. It is more aggressive, and there are no targets we can use benign therapies for. But it tends to be very sensitive to chemotherapy. So that's the summary. So here he put the bad news that there is, it's not very common, but more frequent in a Caucasian, but it tends to be more aggressive in African American. And the patients who have the genetic predisposition to having cancer, that is hereditary breast cancer, specifically the BRCA1 patients, these are patients who are born with an abnormality that predisposes to breast cancer with high percentage. Those patients have a higher risk of being triple negative, having triple negative breast cancer. So this is the bad news, but it's still more bad news. High grade, meaning still in the same, it just means that the cells look very different from the normal cells. That's what the grade means. Different than the stage. So the grade is just under the microscope, the cells look much different than the normal cells in comparison. They're larger, the nucleus of the cells is much looser, they tend to not stick together, be isolated. And higher risk of early recurrence. It's within the same topic. More aggressive cancers, they recur more, they can kill more patients. And it actually has this unique thing about brain metastases, but that is something that's is not so specific to triple negative. All high-grade breast cancers tend to go to when the tumor is still just in the breast and you can measure it, you can see it, you can look at it by the MRI, then you give chemotherapy before the surgery. That's what neoadjuvant means. Give it before the surgery, then you can see the tumor shrink very quickly. Some patients will have pain from the tumor, and they say the next day after the chemo, the pain went away completely. So that you don't see very frequently in other breast cancer. That is very unique in triple negative breast cancer. They tend to quickly shrink. Not a big surprise. The chemotherapy kills rapidly dividing cells. So it just stops the division of the cells when they're in division. The higher percentage of cells in division, the higher chance of them dying. In triple negative, because it is on the aggressive side, the higher, there's a lot of cells in the active division, so they get hit by chemotherapy more effectively. So it's not necessarily the death sentence. The other thing that's important is in the triple negative breast cancer, when it's still localized in the breast, because it's an aggressive tumor, if it's going to recur, it tends to recur more than 80% of the time within the first 2 years. So in this cancer, if you celebrate your 2-year anniversary cancer-free, very high chance you're cured of this cancer. So that is much different than the strongly estrogen receptor driven cancers, because those, it's never okay to just stop following up, because the cancer can recur 15 to 20 years later. So it's about it, it's aggressive. If it's gonna come back, it's gonna come back quickly. But if it doesn't come back within a short period of time, it's gone. So this is an example of a tumor with a lymph node. So this is here this is an MRI of the breast. The woman is laying down on her belly. So you can see this. It looks like a cow that you're about to start milking, but that's laying down on the belly. And this is so she gets a couple of cycles of chemotherapy, and I don't know the particular story about this specific patient, but I'm just illustrating here what shows that the tumor and the lymph node have significantly decreased, probably at least the quarter of the original size. And it looks, this is probably 2 or 3 cycles of chemotherapy, very frequently seen phenomenon. So that was the good news, is it responds very quickly. We can see the response, and we tend to give chemotherapy before surgery in a lot of these patients because they tend to present already with large tumors that tend to be inoperable. But also, it's nice to see the response. And if they go to surgery and there is no tumor left behind in the breast, that is a great predictor of cures. So it's when we do the surgery first, then we go for the chemo next. You don't know if this chemo is benefiting the patients for sure. When you do it and you see the tumor shrink and then you don't find cancer at the time of surgery, it's a very nice predictor of survival long term. So should you do, well, if you feel a lump, come to CTCA. That's the answer. It's pretty clear. So it says here, it's just, you know, I think Dr. Citrin gets frustrated sometimes when he sees women with advanced cancers, neglected cancers, a lot of time wasted. It does get sometimes upsetting. We want these women to be taken care of in a timely manner to save lives, because this is curable disease. So he says here, do not panic, see your doctor right away. Normal negative rate in mammograms. What it means is you can have a normal mammogram and still have a tumor in the breast in 15% of the time. That is pretty high percentage. And if you feel a lump, mammogram or not, it needs to be biopsied, even if the mammogram doesn't show it. We see this very frequently. Patients come to us and says, I felt this. I kept telling my doctors, I can still feel it. It's growing. And the doctor blows it off and says, the mammogram was normal. Doesn't mean anything. You feel a lump, you can biopsy the lump, mammogram or not. It doesn't project very well. I don't know if you can see it well. I believe that is a breast, and there is a tumor kind of protruding with some swelling, and it looks like it's about to actually pop out of the skin. The skin looks very shiny. And there is a chemo port right there, so I guess this patient is about to get chemotherapy. I'm sorry, I don't know the stories of these women here. And here what it says, after you get a lump, find a team of experts that you trust. It's not very available everywhere, but ideally the patient should have, first of all, a nurse navigator. It's very overwhelming to know that you have a tumor in your body that could possibly be a lethal disease, and you call and somebody picks up the phone and says, hold on, and you listen to this music, and then somebody comes back and you have to say your story all over again, and then there's, okay, the next available appointment is three weeks from now, just to actually meet with the physician. And then the physician sends you to a surgeon, and then the surgeon has to find a time in his schedule, maybe he's on vacation, and then there's weeks and weeks go by and nothing's happened. Having a nurse navigator, we believe, is very important because that's the person navigates the system, meaning schedules your appointments, have a plan for you, educates you about all the questions you might have about what each doctor or each specialist does. Why do I need a medical, a radiation, a surgeon, and all these people involved? But everybody has a different role that the typical patient doesn't know. So it's important to have a navigator or an advocate or somebody to guide you through the system and the loops of the system. And it's not everywhere that everybody is in one place. And we're fortunate to have that you can walk over and talk to all these people in the same day, versus in other places, there are different buildings. Sometimes you have to drive a good drive to get to the specialist. So it is important to surround yourself by, number one, somebody helps you navigate the system, but you would need to meet a medical oncologist, a surgeon. In some places, like for what we have, it's not available everywhere, but it's nice to have a naturopath provider because a lot of patients seek natural medicines in addition to the conventional medicine. So instead of, if you type on Google breast cancer, you'll get probably 60 million entries, and you have so much information, and everybody claims that they can cure breast cancer with this natural supplement. And it gets confusing. Patients really want to seek other ways besides just this traditional medicine. And it's important to have a reliable, certified, well-educated person that only deals with the cancer, so they can guide the patient what's important, what's good, and what's just garbage. So I think it's important to have them involved from the beginning, so they don't shop around and waste so much money on things that don't work and potentially can be harmful. A dietitian, there's so much about obesity and breast cancer. It's to the contrary to what most patients will feel. I need to eat good, I need to keep my weight because I have cancer, I need to fight the cancer. It's actually quite the opposite. Breast cancer patients should actually attempt to lose weight, not gain weight. Even if it's not hormonally driven breast cancer, there's multiple studies about the relationship between losing weight and having better outcome, and the other way around. People who gain weight, who are overweight, actually can have worse outcomes. So losing weight is important, and we have a dietitian that can help the patient select. We don't want patients to be malnourished. We want them to eat well, eat healthy. There's a lot about fat, animal fat. Patients have questions about, how about soy? There's green tea. There's so much stuff on the internet that patients have questions about, and the dietitian that specializes in cancer or breast cancer can be very helpful to answer those questions. So the nurse and care manager, at least for us here, is the nurse who actually is liaison between the patient when they go home and us. So if there's questions, if there is contact with other physicians, if there is any complaints or any new things, even unrelated to the cancer, they can call their care manager, and she relates to the doctor and guides them. So that's the link between home doctors, home, and the patient. In other places, they can be used as just the person who you call first when you have any concerns. The other people are pretty obvious what their functions are, but it is critical to have somebody that helps you navigate the system, so you're not frustrated with, what do I do next, and why am I seeing this person? And it really is overwhelming, and we understand that. Then after a diagnosis is established via biopsy, we know it is triple negative or not. The next step is to decide, is it going to be chemotherapy first to shrink it and make it operable, or is it going to be surgery first? If the tumor is small enough, You can move it. It's mobile. It's not fixated. There's not a lot of enlarged glands under the arm. It's okay to go with surgery first. That's what we want. We want to be able to catch these tumors small, not too advanced, to be able to do the surgery first, then learn more about this cancer at the time of surgery, then come back and get additional therapies. And every patient is different. Chemotherapy is typically needed for the triple-negative breast cancers, even if they're very small. Radiation depends whether or not the patient had a lumpectomy, that is just removing the lump, or a mastectomy, meaning removing the whole breast. And sometimes, even after a mastectomy, the patient needs radiation. So that really is taken case by case, but we need to patient needs to meet all the specialists and come up with the treatment plan, which typically is done within a day or two. So it is important to have a very good relationship patient-doctor so we can have better outcomes, be more compliant, be open, know that somebody is there to answer any question of any kind and support you and your family. These are some tools that we use to help the patient with the chemotherapy decision. This is a model that's actually called Adjuvant online. It is worldwide used for the last 15-20 years. It's very well validated. What it does, let's say patient wants numbers, wants to know how much is this going to benefit me, what are my chances for recurrence, what are my chances for cure. So we put in the features of the patient, like this is an age, is the patient healthy or have other medical problems, then the features of the tumor. And then you decide based on the pathology report what grade. So all these are features of the patient and the tumor, and this helps you with the chances of recurrence at 10 years by percentage. Then that will be the red bar. These are the chances of recurrence without any additional treatment besides just surgery and radiation. And then it tells you, let's say, obviously this is if you use hormonal therapies, if it's triple negative, it's not going to work. So there's no change. And this is the benefit of chemotherapy. It reduces that red bar by a little over 50%. It says here 59% improvement. So the chance of recurrence is estimated in this lady at 63% at 10 years, and that is reduced by about 60%. So 60% out of 62%, it improves it by a little bit more than half. And this is an easy visual way of seeing it, and sometimes it helps the patient with how much is the chemo benefiting me? Well, it doesn't make it zero, but it is a substantial improvement. That's it. Questions?
Thank you, Dr. T. That was a wonderful presentation. And again, we want to, at this time, if you could type your questions into the chat section, we will answer questions in order that they are received. I see Marilyn and Kim are typing fast. Again, we want to thank Dr. T. Some of you may not know what it takes to put a presentation like this together, and Dr. Citrin had been working on it for a few weeks, and he was ill this morning, so Dr. T was nice enough to fill in at the drop of a dime, and she really only had about 2 hours to prepare for the meeting today. So we are very excited to have her and to have her be able to come on board and present this morning. Dr. T, the first question from Marilyn. Is there anything different with triple-negative breast cancer in Caucasian women?
Well, there's something inherent to the disease being more aggressive and typically diagnosed at later stages and not responding as well to therapies in African American women. But overall, the triple-negative breast cancer is still an aggressive tumor, still very sensitive to chemotherapy, treated exactly the same way. We don't think any differently. I mean, the differences is just a comment. It's just something we've noticed. We don't do anything differently about it. We still treat both women, Caucasian or African American, exactly with the same way. The fact that there's some differences is some epidemiologic studies that have shown that it doesn't affect how we think about the cancer or how we treat it. I don't know if this answers your question.
Okay, thank you so much, Dr. T. Our next question, and I can actually answer this one, Dr. T. Is there a way to get copies of the slide presentation? The slide presentation will be made available online via the Sisters Network website, and we will also send a link out with the recorded presentation as well as the slides as well. Patrice, the next question is from Patrice. Since we are not eligible for hormone therapy as a follow-up, what is your opinion of HRT to ease menopause symptoms caused by chemical menopause?
It's very tricky because the what I would I'll tell you what is the studies, what is the data available, and what I do. For hormonal replacement therapy, it does not differentiate between whether a patient had triple negative or not. It's just point blank contraindicated in anybody with history of breast cancer. That's the traditional answer. Now, what have we found? Why are hormones bad for women in general? There's some link between using the combination of estrogen and progesterone together for a duration of more than 3 years that have shown an increase in incidence of invasive and non-invasive breast cancer in the Women Health Initiative study. These are hundreds of thousands of women. So it is established that taking external hormones increases the risk of breast cancer. So there is a good percentage of those women who only took estrogen because they didn't need to take progesterone to protect their uterus. That's the role of progesterone, just to make sure estrogen doesn't cause uterine cancer. The women who did not have a uterus didn't need to take progesterone, they took only estrogen. So they went back and looked at those women, and they found that there was no increase in breast cancer in women who took estrogen only. But these are women who never had breast cancer. So this is prospectively, if a woman never had cancer, just wants to know, is it safe to take hormonal therapy? First, I don't use it preventively. I don't ever recommend using it for myself or for my family members. But if somebody is miserable from symptoms of menopause, miserable, and they absolutely need to take the hormone, I say estrogen only and for less than 3 years. Now for breast cancer survival, whether it's triple negative or not, I recommend against any use of hormonal therapy. This woman's body is telling us it's predisposed to having cancer. You can have a new primary. Now if the woman has bilateral mastectomies, no breast tissue at all, and was triple negative before, it's hard for me to argue against the use for a short course of estrogen to alleviate some symptoms. There's no breast tissue, and the original cancer was triple negative. But if there is breast there, no hormones at all, because that breast told us already, it can cause cancer. Maybe next time it will be hormonally driven cancer. Maybe there are microscopic cancer cells there that if we give them hormones, will stimulate them. So I tell my patient I disagree with you taking them, and if they take them, I'll just watch carefully.
Okay, thank you, Dr. T. Our next question comes from Kimberly Watts. The question, with implants, how do we self-exam? All I can feel are the implants. My surgery was 9 months ago.
Well, I believe anybody would just feel the implant. So it's not an expertise problem. It's just the fact that the breast, it depends on when the implant is placed. Sometimes the implant is placed under the pectoralis muscle, in which case you can still feel the breast tissue over that. And sometimes it's very superficial, in which case you really can't feel the breast tissue at all. So it's not really, you're not going to depend on self-breast. We should never depend on self-breast examination as a screening method. It's an additional thing, but it has never been shown to improve survival. So it's nice to make women aware of their breasts, but don't feel bad if you can't feel a thing. It's not going to help you too much anyway. So these women actually will depend solely on mammograms. Even the physician may not be able to feel something behind the implant. We encourage implants under the pectoralis muscle because that will allow you to still feel the breast comfortable. But if not, it's mammograms or possibly MRIs may be necessary to follow that patient.
Thank you, Dr. T. And that was a great question, Kimberly. The next question is from Mindy Williams. Does pregnancy after treatment for triple negative increase the chances for recurrence?
Nope. Pregnancy has never been shown to increase recurrences of any cancers, any breast cancers, hormonally driven or not.
Okay, thank you. The next question says Kelly Hodges, but it's actually Nicole Dove, who's a survivor that works here for Sisters Network that helps to manage Webinar Wednesday. Her question is, how has treatment changed since 5 years ago?
For early stage triple negative?
Yes, early stage triple negative. Mm-hmm.
Sad, but we have not gained a lot on our list of options. But we have learned so much about it that I believe in the next 5 years we may have many other things. What we tried to focus on in finding targets in triple negative breast cancer. We don't have the traditional targets, it's triple negative, but can we find other targets inside the cells that we can focus on? And there's one big thing was the PARP inhibitors. What is it? Is a way for the cell to repair DNA damage. And we found that in some BRCA positive patients, they have a deficiency in that PARP, in the mechanisms of repairing DNA damage. So we felt like if we can damage the second mechanism of the cell to repair DNA, we can kill cancer cells easily. So the PARP pathway is a good target for triple negative breast cancer. Unfortunately, when they did the study, they found that the PARP pathway is only really important in the triple negative breast cancer that is genetically driven. It is from the BRCA positivity, not necessarily for all triple negative. But there are still some triple negative that are similar to the BRCA positive patients. So that is kind of a big advance. The PARP inhibitors are now on trial for BRCA positive patients. Nobody has given up on them yet because they still believe there's subtype of patients who will still benefit from the PARP inhibitor, whether genetically driven or not. So that is a good target, but there are at least 5 or 6 other targets in the triple negative patients that are being studied. There's some preliminary data, nothing really out in the field yet. The only advance was made is to now we know that they're not all equal, they're subtypes. We're starting to find some targets of therapy.
Okay, thank you, Dr. T. The next question is from Marilyn. She has a 2-part question. The first part, Dr. T, I'm going to email that to you because it's more specific to her case. But the second question is, does triple negative spread? I'm sorry.
Triple negative because it's
I'm sorry, it's an additional question, Dr. T. I'm sorry, I didn't see the second part. It says, does triple negative spread any differently than hormone-sensitive breast cancer? I realize it is typically more aggressive.
Right. So this is not really official, but from experience, all of them can spread to any place. Could be brain, could be bone, it could be. But typically, the hormonally driven cancers really have a high percentage of having bone metastases, and a lot of the times only bone metastases. And those patients have a very good prognosis and very long-term survival. So this is not the case for triple negative. A lot of the times it's organ metastases, visceral metastases we call them. That means lung, liver, or brain. More common in the triple negative than in the other cancers. So the typical course of an ER positive, PR positive cancer is bone only for many, many, many years. It can be controlled and treated. And then all of a sudden, organs start getting involved. Triple negative, first thing, lung, brain, and liver, and then so it's not, there's no kind of a long, sluggish break before you get to organ damage. So it does progress differently.
Okay, thank you, Dr. T. Since the next question is from Patrice, since we do not have follow-up meds, what is the most important thing that we should do or should be doing to avoid reoccurrence?
So number one thing that I recommend to my patients is lifestyle changes. I do realize that the contribution is not very big, but that's something the patients themselves can do. And mainly weight loss and exercise and changing the diet significantly, minimizing the animal fats in the diet and increasing whole grains, fruits, and vegetables. That should make 80% of the diet. So I think that really changes the outcome of patients, survivors of breast cancer, just maintaining the weight and the exercise. The other thing is the being really sensitive and responding to your body. Any new symptom that's not really going away within a couple of days should be brought to your doctor's attention. Now, there are no recommendations to do routine scans or routine blood work by the guidelines. That being said, I really typically go by my patient's wishes. I do understand this is a lot of anxiety, so if the patient tells me, I really want to know if I'm clear and I have no cancer, and usually my response is not that the book says you're not supposed to get CAT scans or blood work. If the patient wants it and insurance covers it, I get it done, at least for their mental health. And sometimes we'll pick things up. But it's not wrong for the local physicians to say it's not necessary to do those. By the book, it's true. There is no need to do blood work and scans. But I do it for any hint of symptom that the patient is worried about, whether it's a headache, a persistent cough, an unusual weight loss or weight gain, a new bone pain anywhere. We should be brought to the attention immediately.
Okay, thank you, Dr. T. We have another question from Kimberly Watts. Actually, Kimberly, I'm going to defer this question and email it to Dr. T for her to answer on the side, if you don't mind. The next question is from Sisters Network. On slide number 6, where is the statistical information that African Americans refuse treatment? Where did you get this information from that backs up this statement? So we'll go to slide 6 real quick.
You know, these are not my slides, quite honestly, and I'm not a big believer in that. There's some epidemiologic studies showing that there tends to have a delay in the diagnosis, and maybe I think this is a fear. If women, I typically don't tend to be upset or angry at the women who are. I typically just understand that they're scared. There's a lack of information.
Audio with Dr.
They probably
T.
don't know. There is a fear. There's a fear that the chemo is worse than the cancer. There's a fear that the treatment is going to be more harmful than beneficial. There's a lot. It's not just unique to African Americans. It happens in a lot of different backgrounds, including Caucasians, Hispanics, everybody. It's just, I don't see that much refusal of treatments once the patient understands what's happening, risk-benefit ratio, they understand they will be supported. I've never had an experience that African Americans refuse treatment more commonly than others. I actually don't have a lot of patients who ever refuse treatment once they're well informed. Very, very, very unusual or uncommon that the patient just says, I don't want to be treated just because I don't want to. It's usually a fear. You have to go to the bottom of the problem. Why? Why are they scared? Why are they worried? What are they worried? It's usually like a grandmother who died in front of their eyes with chemo, and maybe it's a bad experience from 20 or 50 years ago. It's usually some reason. It's not just because they happen to be African Americans, in my opinion.
Thank you so much, Dr. T, for that. We have one more question from Jackie, and her question is, if you have a hard time losing weight, would it be safe to have weight loss surgery?
Yes. We try all the other means, and trust me, we have some successes and a lot of failures with just diet and exercise. It's very difficult. We understand that. And I do if the patient qualifies for the other ways and it's safe for them, why not? It may benefit them overall, including in breast cancer recurrences. I am a big proponent of doing whatever it takes to lose that extra weight.
And I'm sure we're glad to hear that, Dr. T. We have another comment from Sonia Franklin. It's not a question, but a statement. She wanted to thank you for your presentation. And she is a 3-time breast cancer patient, first diagnosed in 1999, and she's presently in treatment at Cancer Treatment Centers of America in Atlanta. And she's found that this place is great. And I'm losing my place because so many people are now typing. Found this place to be great, even if there is not more treatment available within the past 3 years. It's very great to know that at least more talks are happening. Thank you, Sonia, for that comment. All right, and we have one more. We'll take one more question. And this is from Maryland. Oh, actually, these are just comments now. Everyone is telling you that it was a very quickly. And again, thank you so much. If you have any additional questions that may not have been answered during the presentation, you can actually send your questions to Kate Peterson. She's the marketing specialist at Cancer Treatment Centers of America, and her email address is on the screen. It's kate.peterson@ctca-hope.com. And for those of you who typed in a question, I'm going to send that question to Kate as well, so you don't have to resend your question. I will send those over to her. But if you have additional questions, you can go ahead and send those as well. And again, on behalf of Sisters Network, our national board of directors, our affiliate chapters, and volunteers, we want to thank you for joining us for our first Webinar Wednesday, Triple Negative Breast Cancer, Dispelling the Myths about Triple Negative Breast Cancer. And please join us for Intimacy in Cancer on February the 13th, The Woman in the Mirror. Please hurry up and sign up. Our slots are filling up fast. And thank you all so much for your support of Sisters Network. And if you have any additional questions, this is our contact information on the screen. The evaluation for this webinar will be sent by email to you by the end of the business day tomorrow. And in the meantime, if you have any additional questions, you can contact us at info